All right, we're going to get started. Good afternoon, everybody. Welcome to the School of Public Health noon seminar meeting. And today's seminar is going to be given by Dr. Adelaide Masu. And Adelaide is actually based at the Department of Pediatrics and Child Health. She is a clinician and pediatrician, and also has done masters in epidemiology and is involved in a lot of clinical teaching at the Department of Pediatrics and Child Health. And Adelaide and VACFA, which is in the School of Public Health, has had long-standing collaboration in the space of vaccines and immunization. So we have several projects within VACFA that investigate issues related to vaccines and immunization with the context of translating those research findings into policy. Largely, most of the work that we do at VACFA focuses on strengthening immunization programs, not just in South Africa, but in low and middle income countries. So Adelaide's work that she has been doing with us at VACFA is looking at vaccines and immunization decision-making ecosystem in 4 Southern African countries. And this work was informed through the collaboration that we've had with our stakeholders, asking the question, how is the process of making decisions, may it be on vaccine introduction or may it be on changing the use of existing vaccines, could be change of the dosage, could be also the change on the vaccine type that is being used. And that is what Adelaide is going to present to us today. So Adelaide, over to you, and we look forward to hear your talk. Thank you.
Thank you, Ben, for that introduction. I'm just going to start presenting, but I'll switch off my camera during the presentation, and then I will switch it on for the Q&A, just for the sake of bandwidth. Okay. Can you see my slides?
We can see your slides.
Okay, thank you. So I'm going to start. Okay, thank you very much, Ben, for the very kind introduction. So as he has mentioned, we're doing this on a study that VACFA was doing on vaccine decision-making in 3 Southern African countries. So just a bit about the background. We know that vaccine decision-making is very important in terms of how we arrive at what vaccines to use and what vaccines to prioritize. And it is actually influenced by many competing health interests in the country, such as other diseases, non-communicable infectious diseases, maternal and child health. So there are many things that are competing interest. We also know that it's influenced by different stakeholders and different factors. We know that NITAGs play quite an important role in most countries now in the world, and especially in Africa. And their role is to make evidence-based recommendations. And we also know that surveillance system of vaccine preventable diseases are important in terms of generating data which informs which vaccines are priority in the country and how effective a vaccine program is. So the aim of this study was to describe vaccine decision-making in Namibia, Botswana, Eswatini, and South Africa. There were three main objectives. So our primary research question was, what are the factors Sorry, I'm trying to minimize this, but it's not happening. So, what are the factors and stakeholders influencing vaccine decision making in Namibia, Botswana, and South Africa? And the two secondary research questions are: what are the facilitators and barriers faced in vaccine decision making in these four countries? And lastly, how has the EPI in the selected four countries evolved since the launch of these programs? So, just in terms of the method, this was a qualitative study. The first phase was to recruit studies of the stakeholders for the study, and we categorized them into four groups based on some of the literature review we had done. So, NITEG members were important for us to interview. We looked at technical support and assistant partners, WHO, UNICEF. We looked at Ministry of Health representatives, such as the EPI managers, and then the Ministry of Finance representatives. This was an interview, so semi-structured with an interview guide. They were 1 hour long. They were on MS Teams, and we recorded and transcribed the interviews. For the data analysis, we used NVivo version 12, and the data was reported narratively using a thematic analysis with deductive methods, and we used Burchett et al.'s vaccine decision-making framework when doing the analysis. So the results we got, there were 3 countries. Eswatini declined to participate, or rather, they did not decline, they just did not agree to it. So we have Botswana, Namibia, and South Africa. In total, we had 8 respondents. So either NITAG members or WHO members or API managers, but there was no Ministry of Finance representative, unfortunately. So I'm going to report the results in terms of these different subcategories. So I'll discuss what the discussion was around priorities, stakeholders, what were the factors, what we found out about the process, what were the facilities and barriers, and then the role that surveillance played. So in terms of the priorities, so we during the interview, we found that there were competing interests in terms of vaccine introduction, and one of the participants mentioned that COVID-19 pandemic had been for their country a priority that shifted the focus away from the national immunization programs and introduction of other vaccines. And then other competing interests which were important were natural disasters such as floods and drought. One of the countries had experienced drought and diverted resources, as well as areas where there was conflict and humanitarian crisis. In other countries, they mentioned that vaccines were a health priority and that if a vaccine is to be introduced to the country, other conflicting health interests would be considered in comparison to that, and the vaccine would be prioritized. So when we discuss the issue of are there particular vaccine preventable diseases that are targeted by available vaccines that were a priority, participants mentioned that, in fact, they believed all the vaccine preventable diseases in the EPI schedule or the NIP schedule were, in fact, priorities. However, there were some people who mentioned specific ones, such as polio, and the comment was around neighboring countries with outbreaks affecting, making it a priority in their country. Measles was mentioned because of frequent outbreaks, and rotavirus outbreaks were also mentioned. So in terms of the stakeholders, so NITAG was cited as one of the main stakeholders, and their role was to give evidence-based recommendations. And in these countries, the recommendations the NITAG had recently made had been adopted for government. But there was noted that they needed to be more support for this role through secretariat support and also availability of resources. Government was another important stakeholder. So as we would expect, the Ministry of Health is quite key, and their role was around motivation of funding, being the final decision making, and also their role in the implementation, development of a vaccine program and plan and the implementation of that plan. The role of Ministry of finance was highlighted as finding the budget for the vaccine. But what was also interesting is that other ministries were quite important, and there was the Ministry of Education and Family Sector in one of the countries because of the importance of intersectoral collaboration for vaccine implementation. The role of assistance partners was also highlighted. So WHO UNICEF was seen as providing logistic support by the provision of experts and also being part of technical working groups around vaccination. And of course, for some countries, the SAGE recommendation were a stimulus for the discussions around introduction of new vaccines. So the role of Gavi and the pharmaceutical industry. So Gavi, the alliance, was not involved in any of these countries. All the countries we interviewed were self-financing, except obviously we had wanted to include Eswatini, which we couldn't, but they funded HPV from Eswatini, which had been previously a self-financing country. But the role of the pharmaceutical company industry was to see that they could get the vaccine registered, because it has to come through a medical industry or company. And then they also provided information about the vaccine product. So, for example, if different stakeholders like government or NITAG or, they would provide, detailed information about the vaccine product, the vaccine product that they were producing in the market. So in terms of the process, so there was a similar general processes in all the countries. Often it would start with the Ministry of Health requesting an evidence-based recommendation on a vaccine that they needed. NITAG would then make the recommendations after deliberation and obviously independently. Then the Ministry of Health would make the decision or adopt the recommendation or not. But in this case, they did. And then it was up to the implementation EPI team with assistance from NGOs to look at the implementation of the vaccine. Factors which were important. So the role of politics and the political landscape was highlighted. And in these countries, there were actually high political will for the adaptation of vaccines at the highest level. However, at some of the lower levels, there were issues such as change of leadership, which affected vaccine decision-making implementation within the different programs. And it was also highlighted that they felt that some of their leaders who were working in vaccination or who were managers or leaders within the immunization space actually lacked a background in immunization, and they seemed to be in their position more because it was a political choice rather than being technically well-versed in immunization. So in terms of consideration of the vaccine product, most countries say that vaccine safety and effectiveness was the most important thing. Second thing was the availability of vaccines in the country. So, if they wanted a certain vaccine, talking about a particular vaccine product, and it was not available in the country because the company had not registered it in the country, then they didn't really have a choice. They would just choose what they had. So efficacy based on studies was very important. And once efficacy had been established, the choice of vaccine product depended on price factors. And of course, cost was always a consideration, although in none of these countries did cost stop them from adopting a vaccine. The importance in terms of population. So there were target populations that were highlighted. Mother and child were the priority populations. But also in these countries, because of such a high burden of HIV, the HIV population was an important target population, especially because certain vaccine-preventable diseases were much higher in that population and resulted in higher mortality. And for example, pneumococcal would be an example. And then recommendations were made by NITAG, as I mentioned, and then adopted by government, and WHO SAGE could be a trigger for recommendations. So a very important consideration for vaccine introduction was the impact on the health system. So what is the cost benefit ratio in the introduction of a vaccine. So there was mentioned that, they looked at hospitalization, they looked at antibiotic use, and they looked at death and how the vaccine could mitigate these. But there was also the mention of how introducing a vaccine impacted the health system. And one of the things highlighted was that there's an expanding number of vaccines that are being introduced, including maternal vaccines. But the team that delivers the vaccines at the clinic or at the health center is not expanding and is not changing. So what's happening is you're basically increasing their workload without providing resources for them to successfully implement the vaccination program. So what were the facilitators? So one thing highlighted was supportive legislation. So in one of the countries, they say that the right of right to health care and right to health was enshrined in their constitution, and that helped them when they had to motivate for vaccine because health was considered a basic right. Right. And then there's also a mention around strong local data. So in some countries, as I had mentioned, there was the unique context of the HIV burden, and then the issue around strong local data was local research done by universities also supported the adoption of vaccines. So the presence of a strong immunization program was important. So people mentioned, or the participants mentioned, strong management as being important for a strong immunization program. The role of the university in terms of policy development was important, and the presence of NITAG also contributed to as part of creating strong immunization programs. In terms of local manufacturing, one of the things highlighted about local manufacturing was its ability to increase vaccine availability to the countries, especially in Africa, which is a huge market. And obviously, the most obvious example that comes to mind was the COVID-19 vaccine and the shortages of vaccine to give to the lower middle income countries. But another one that was quite important is the HPV vaccine, so human papillomavirus vaccine. So one of the countries had passed the recommendation, NITAG had passed the recommendation. It had been adopted by their Ministry of Health, but they simply could not get stock. And so the delay in introduction to the second half of this year, when a decision was made in 2023, really had to do with stock availability. And then they bemoaned the lack of investment in Africa in terms of vaccine development in this country and local manufacturing capacity to make more vaccines. Communication and coordination emerged as another important theme. So this was communication and coordination among immunization stakeholders, which looked at both among local stakeholders, but also among global and local stakeholders. And it was highlighted that ongoing communication, and this was the technical support partners who were highlighting that ongoing communication amongst each other and with the other stakeholders hastened or strengthened vaccine recommendation to implementation, as well as not just during when the vaccine was being introduced, but also between phases of vaccine introduction. The role of the community was highlighted. So one or two of the participants mentioned that actually the community should look at vaccines as a right. So they have a right to access vaccines and they have a right to vaccination as part of a right to health, and that they should be included at the center of decision-making processes, especially now with a lot of issues around vaccine hesitancy. Involving the community was seen from the onset as being very important. And then the affordability and accessibility of vaccines, which tied into the rights of the community to access the vaccine, but also the issue of equity came up in terms of vaccine access. So advocacy, healthcare workers were seen as advocates, and so were other partners such as WHO and UNICEF were seen as advocates. And there was also the issue of what is the role of academia, what is the role of higher education institutes, and what came through with the training of immunization program workers was obviously a role that was important, and curriculum development in the undergraduate and postgraduate level to introduce immunization concepts, vaccination, vaccine programs, decision-making around vaccines at those levels, and not just to wait until these people were qualified nurses, qualified doctors, or qualified in whichever field they chose, to now start getting training on immunization. So what were some of the barriers? So vaccine registration and vaccine hesitancy. So registration just meant that if a company, if a certain vaccine product was registered and another wasn't registered, that would determine what the vaccine availability would be. And then there was vaccine hesitancy, and the issue of access to technology and social platforms became an issue in generating and mushrooming of vaccine hesitancy in groups that were previously not hesitant, and also the issue around misinformation on social media platforms. So I've mentioned the lack of human resources, so lack of training was a barrier, and poor health systems or fragile health systems with hard to reach populations. Financing in these countries, most of them were self-financing. And I mentioned that the cost of vaccines only came into play once efficacy had been cleared, and they had a choice of vaccine products. So then they would choose which of the products they would have were more cost effective. And there was no country in which recommendation was not adopted because of finances. So then we interviewed the participants a bit about surveillance, just to understand how surveillance plays a role in vaccine decision making in their country. So the presence of local data. So for some of the countries, they did have quite established research institutions, and for certain conditions had very good data. But there were quite a few participants who mentioned that they didn't have the capacity to generate local data, and so they used neighboring countries' data. And then there were several components that were mentioned. So outbreaks, environmental surveillance, sentinel surveillance, case-based surveillance. And there was a shared use of resources in terms of surveillance. So for example, the laboratory networks, there was a particular country that had quite advanced laboratory networks, and the other country sent their specimens and the things that needed analysis to them. And then in all these countries, their surveillance was government funded, except for the polio programs that had catalyst funding from WHO and the Global Polio Initiative. But apart from, small seed funding, government took responsibility. So just to bring this together in discussion. So the issue around competing interests, as I've mentioned, and the issue with them was that some of this was beyond the control of the Ministry of Health. So like I mentioned, the flooding, the war was something that could not be controlled, or could not be, decision-making could not be impacted by the Ministry of Health. I think in terms of the stakeholders, what was important is that other studies have shown that, in fact, a lot of studies don't mention the role of other government ministries, but some studies do highlight that is important in terms of vaccine decision making, in terms of the implementation of the vaccines and collaboration around vaccines. So I think that was quite unique in this study. That's not usually mentioned in the literature. The role of NITAGs. So people's perspectives on the role of NITAGs varies depending on the country. So a lot of these countries had new NITAGs recently formed. But in the literature, we find that there's some people believe NITAGs are very important, and especially their role as independent, making independent evidence-based recommendations. But there are other people who, in the literature, have shown that they do not think that the role of NITAG is important, and that, in fact, they are out of touch with the reality because they are not involved in the immunization vaccine decision making in terms of implementation or contact with other stakeholders to gain deeper understanding of the systems and the processes. The pharmaceutical industry in this study, as I mentioned, were mainly to do with vaccine registration and information on vaccine products, and this has been seen in other countries. But there are countries in the world where, in fact, the pharmaceutical industry plays a much stronger role, such as solicitation of solicitation of procurement industry departments in order for their vaccine to be the vaccine product of choice. WHO perspectives see themselves as being integral to the vaccine decision-making process. But what was highlighted in terms of WHO and even mentioned about Gavi is that sometimes a country will set priorities for the introduction of a vaccine. So for example, in Uganda, I think they had set if I remember correctly, the goal of introducing a rotavirus. But because at the time, human papillomavirus, HPV vaccine, had been considered to be quite important globally, they had to shelve what they thought were important for their country in order to adopt recommendations that funders and donors were pushing. The role of the university, so the university's role was seen, and in other places has been seen beyond just providing academics. So there's a lot of literature in South Africa where, the university produces the researcher and the research informs decision, or the university produces experts that sit on the NITAG, and this informs decisions. But the role of the university could be broadened in terms of providing intensive education, as I mentioned, to both undergraduate and postgraduate. And in terms of in-service training, they could have a role. I know that certain universities like, Stellenbosch do have a course on a hands-on immunization programs, but this could be broadened. In terms of finance, the issue of sustainability is very important. And as I've mentioned, priorities for countries, especially in low and middle income countries, which are Gavi funded or have other funding that's Melinda Bill Gates or have other funding available to them. So when that funding goes, how do they sustain their vaccines and their vaccine programs? Vaccine equity, I think in one of the countries, it was mentioned as something important, but I think the issue of vaccine equity also speaks to some of the differences that happen between the private and the public sector, where, for example, a vaccine which is seen as important to a certain population in the country is available in the private sector, but is not available in the public sector. So how do we bridge that gap and make sure that vaccine access is equitable? So local manufacturing, there are 8 countries in Africa, as during which the study was done, I don't know if there are more now, that had manufacturing capacity, and not all of them had manufacturing capacity from the beginning of the vaccine production to the end. Some just had, for example, filling and the last parts of the vaccine manufacturing process. But there's a move now internationally to look at investment in African vaccination capacity, especially because Africa is being seen as quite a huge population of people who need vaccines and who need to use vaccines. And the issue has just been around getting investments by other stakeholders such as big pharma and government and non-governmental organizations to invest into Africa's vaccine manufacturing capacity. So vaccine hesitancy came through as I mentioned, as an important theme. And I think the issue around that is what are the strategies that can be employed to mitigate that? And I think what was interesting is that healthcare workers, even though they work in vaccination and they work in health, were some of the people who pushed hesitancy, especially during this previous pandemic, and communicated to the communities that, in fact, these vaccines were not safe. And so one of the issues is, do we not try and target healthcare workers to make them vaccine advocates and facilitate vaccines, whether it's provision of the information that is needed, or whether disclosure of what the adverse effects can be and how we manage them in the healthcare system. The other thing about vaccine hesitancy is that religious groups have also come quite forward. So apart from social platforms, but religious groups, so churches, other sectors have also stepped in and encouraged vaccine hesitancy in some of these countries. And they become also an important target in terms of strategies to combat that. And then funding of surveillance systems. So most of the systems in Africa are very poorly funded in terms of surveillance. And it should be a priority because it doesn't only tell us about, what vaccine preventable diseases are out there, the burden of disease, but they also tell us the effectiveness of the immunization programs in those countries. And so there needs to be strengthening around surveillance system and more funding available for countries to successfully institute these systems. So the limitations is that there were very few participants. As you could see, there were 8. And we also did not get representatives from the Ministry of Finance, so that was also a limitation. And then, of course, those people who decided not to respond, we're not sure why, and I think that also introduced bias. Thank you very much. That's the end of my presentation. I'll take questions. Hi, Adina, I see your hand.
Hi, Adelaide. Thank you very much for that great presentation and for sharing the findings from the study. And as you were speaking, I was taking note of the unique kind of socioeconomic situation of the 3 countries that were part of the study, and how we may interpret the findings or draw lessons learned for other countries on the African continent that may have different socioeconomic status, or may, for example, depend on Gavi in terms of procuring vaccines and how that influences their vaccine choice. So I think basically my question is, how do we draw lessons learned for the broader continent, given the varied socioeconomic conditions?
Thank you, Adina. So I think some of these things are cross-cutting, whether you come from a low middle income country or a low income country. So, I'll give an example. NITAGs and their evidence-based recommendation is something that every country should have and can benefit from. Obviously, these 2 of the countries had introduced NITAGs the year before, in fact, the year of the study. So for countries that don't have a NITAG, for example, that is something that they can look to introduce, which will improve their vaccine immunizations space. I think other things like technical support and of the role of technical support partners and the way they relate to each other and they relate to the countries. I think that's something that countries can address in terms of communication, ongoing communication with them, coordination of the services. I know that I did mention that there is pressure from technical support partners, but I think they can also be allies. And I think that's something, that kind of relationship that countries can work on in terms of with those technical support partners. So, for example, one of the countries had a very good working relationships with their with the Ministry of Health, the stakeholders, including NITAG and the Ministry of Health. So I think that's something that can be done to cultivate those relationships. I also think more of a collaborative approach in terms of intersectoral approach for in the government. I think that's something that can also be done quite well, because I think if you're able to, bring aboard the Department of Basic Education and the Department of, I mean, I don't know, the ministry, different countries have different ministries. But for example, with the HPV, if you're able to bring on the Department of Basic Education and collaborate with them effectively, and every country has, a Department of Basic Education, then it, for example, can promote introduction of certain vaccines like HPV into the community. So I think those are some of the lessons that I would take away. And then obviously vaccine hesitancy, which is a huge problem. It's an increasing problem in Africa. And I think certain strategies like targeting healthcare workers, targeting religious leaders to create the right messaging around vaccines and to combat vaccine and provide information and accurate facts and engage those who are hesitant. I think that's another strategy that, because we find these people in every community that can be, that can be taken away. And also the role of universities. We know that not every country has a research capacity that some countries like South Africa have, but they do have undergraduate programs, they do have postgraduate programs. They can have a section of their courses, dedicated to looking at vaccine. I mean, for example, I trained in pediatrics, but I can tell you that my knowledge of vaccines increased exponentially once I joined VACFA. I mean, I worked with VACFA on this project. So I think those are just some of the things, yeah.
Thank you, Adelaide.
Okay, if there are no other further questions, I think thank you all for attending and for coming to listen to some of the work that we're doing at VACFA. And thank you very much. I think, Carmen, I'll hand back to you.
Hi, did I miss anything? I just stepped out of the room for a minute. No?
Yes, I'm saying I think we're done. Yeah.
Sorry?
I said I think we're finished now. We're done.
Okay.
Yeah.
Yes. Oh, okay. Great. And